iris fixated lens in children with ectopia lentis, where there is subluxation, and the subluxation can vary from lesser degree to gross subluxation, where the lens needs to be removed. Then for visual rehabilitation, what is the thing that we need to think about? My choice would be iris fixated IOL. Now, why did I think it is iris fixated and not SFIOL? We have our own a good number of articles which says it is safe, effective, and definitely a easy technique to implant this intraocular lens. Most important in high volume surgeries, in institutes where high volume surgeries are being done, we think of time. So definitely iris fixated has less time involvement as compared to SFIOL. Learning curve is much shorter and less long-term complications as revealed by our own articles. Well, looking at the indications for surgery is first is not all subluxated lens needs to be operated. We have to consider few parameters wherein we can think that this lens needs to be removed even though if it's clear lens. Sometimes it can be cataractus, and if it is cataractus, then definitely it is one of the indication to remove it. If there is diplopia and there is unstable refractive error, or there is a gross subluxation, that is one part of the pupil is aphakic and the remaining is phakic, or it can, and you feel that clinically this lens can get dislocated either anteriorly or posteriorly by looking at the zonules in a dilated pupil, we can think of operating this patient. And if there is a raised IOP, definitely it is an indication. Now, there are few parameters that I would like to always consider before planning for IFIOL is the anterior chamber depth, because I need to be very comfortable when I am operating. And I also analyze the pupil size. If it is less than 6 millimeter, I would plan for an anterior approach of fixing the IOL. If pupil is slightly larger, then I would ask the vitreoretinal surgeon to implant it. And most important is to do a good anterior vitrectomy. And at the time of doing anterior vitrectomy, I prefer to do a peripheral iridectomy at 12 o'clock in children especially. Now there is a debate whether we need to do peripheral iridectomy or not. I leave it to the surgeon. Definitely there is a gap between the IOL and the iris tissue after doing vitrectomy. This space should be enough for the flow of the aqueous chamber. But as been practicing for almost 20 years, I prefer to do a PI. There's nothing wrong in doing it. And there is an alternate route for the flow of aqueous. I prefer the limbal approach because I'm an anterior segment surgeon, and although earlier when I was doing, it was used to be a primary intraocular lens implantation. At the time of removing the lens, doing anterior vitrectomy, then I would place the IOL. I would face a lot of post-op inflammation. So I plan to do a secondary IOL implantation. The various lenses that are available are from the Excel company, Excellent High Care Group, and I have no financial interest in this. I prefer the Excel Lens Group because I've been implanting for almost 15 years now. Earlier it was 9 millimeter overall length. Now they have shifted to 8 and 8.5 millimeter, and the powers that are ranging are wide range. Earlier we had a narrow range of powers. Now it's from +6 to +30 diopters, and the A constant we have to keep in mind, it is different. It is 117. So roughly if you have done it for 118.2, then you can deduct about 1.5 diopters from it. Simple instruments are required, not any complicated instruments. You need the iris claw forceps itself. I prefer this, which I've been using for almost 15 years now, and dialer, which is straight, it doesn't have a bent tip, just to tuck the lens in the iris tissue. Now this procedure involves a 3-step technique. First you implant the lens in the anterior chamber, rotate it wherever you want to tuck it. Then the third step is the enclavation, that is, which part is enclaved? The mid-peripheral iris tissue is enclaved. This is the most important technical part. Now I'll just run a video. This is quite a gross subluxation. This subluxation more often we see in children with Marfan syndrome, homocystinuria. Here I am doing a continuous capsular rhexis. A gentle hydrodissection is carried out. And I've also used the iris hooks in one part of the cornea, and I have retracted the capsular bag there. I'm doing a dry aspiration of the cortex, and then the whole capsular bag is removed out using the utrator forceps, and you can see it comes out very easily. That shows the integrity of the capsule and the zonules. A good anterior vitrectomy is carried out, and at the same time I do a PI at the 12 o'clock position. I always prefer the scleral section, though many surgeons do it and enter the corneal area. This is another situation where the anterior lens is dislocated anteriorly. I'm using a vectus and dialer to bring it out. Since it's soft, it does get cheese wired. But the anterior hyaloid face is intact. Most of these children have a good anterior hyaloid face. So no need to fear about vitreous drag. I'm injecting some more viscoelastic and bringing out the remaining part. Most of this...
you can just continue.
Most of these eyes are myopic, so these children need to be followed up with retinal evaluation. No, the video, can you run the video? No, forward it. Now I have actually placed the lens and tucking it, and you can see my left hand instrument is a straight rod, which just gives a push on the iris tissue. Inject the viscoelastic, and you can do it, tuck the other haptic. What is important is to have the side port exactly opposite 9 and 12 o'clock. That is most important. And it should not be a tunnel, it's more like a stab incision so that you get good inclination and the pupil is been round. This is one of the complications where the haptic can get disengaged. So now the haptic has come on the iris surface. It's a late complication. All I have to do is reoperate and tuck it in. But what happens is if it goes behind, then the vitreoretinal surgeon has to tackle it. The pupil is quite round. The 9 millimeter lenses used to give good round pupil. That's what we want. And the 8 mm, of course, it's technically easier to implant. There's yet another situation where there is a limbal stretch and secondary glaucoma, and this is a Weil-Marchesani syndrome, a child with this syndrome, where the lens is removed. So these are the few indications where you need to remove the lens and we need to visually rehabilitate, and this is my choice. Thank you.
Yeah, thank you, Dr. Kavitha. Just before I think going to some of the questions, I welcome Professor Rohit Shetty from India, from Narayan Nethralaya, who will be moderating this session. Also, I welcome Professor Anand Bandari, Professor and HOD of Ramaya Medical College, and Dr. Elan Kumaran, who is the treasurer of Karnataka Ophthalmic Society, and Dr. Professor Bandari is president-elect of Karnataka Ophthalmic Society, and Dr. I think here no need to introduce Dr. Rohit Shetty. Everybody knows him. So it was excellent presentation from Kavitha, and I think any questions from the audience, I think you can take a few questions for 1 minute.
Endothelial status, isn't it? Yeah, there is.
Yeah. Because see, now this iris is not going to be fully stable. It's going to be some mobility. Some, like, these are children. They are going to have a very active lifestyle. So sometimes they have like a temporary blurring. And what is the endothelium count in the long run? About 10, 15, 20 years, do you have anything, any such
No,
your
we
experience?
have evaluated, but there is a decrease in the endothelial cell count. There
But
is. There
is it more accelerated than the normal, or is it just like
It's
a routine?
almost the same. It's almost the same, but the thing is now this is posterior enclavation. So that's an advantage. We are not enclaving anteriorly. So that is another option too. You can enclave this lens on the anterior surface of the iris. Probably that would have a greater effect on the endothelial count. But we are enclaving, though this is slightly difficult to go behind, hold the lens behind the iris surface, posterior surface of the iris, and then enclave it, especially in post-vitrectomized eyes. And if you are doing it in first sitting, the eye becomes very soft and they are myopes. So you cannot enclave these IOLs. But we are fixing it posteriorly.
Okay,
So I take it as a secondary sitting. So I presume in the long term, the endothelial count, there will be a decrease. Any surgery,
No.
there will be a decrease, but not much as compared to the PCIOL rates.
No, because madam, when you said that for scleral fixation and this iris fixation, so do you think the endothelium count will be more
I have not
affected as compared to the scleral fixation?
No, I
That
have
was
not
my
compared.
thinking.
No, I have not compared.
Okay.
I
Thank you.
think it won't matter. Means the plane of the lens is almost similar, just behind the
Thank you,
iris tissue. Thank you.
Thank you, Dr. Kavitha. I think let us go to the next presenter, Dr. Anant Rudraramegowda from Coimbatore, who is a prolific phaco-refractive surgeon. I think he is chief of Lotus Eye Hospital, Coimbatore. Over to you, Dr. Anant.
Thank you, sir. At the outset, thanks to the Neon team and Christopher Kudlu on behalf of KOS has given us this talk. Thanks for the opportunity, sir. So I'll be talking to you on topography interpretation in patients for refractive surgery.